Good evening to those who have joined already. We'll give people just a minute or two to join, and then we'll go ahead and get started with this evening's seminar. All right, we'll go ahead and get started. Thank you so much for joining us this evening for our seminar on equine tendon injuries with Dr. Shannon Connard. Before getting started, a couple of announcements about our upcoming seminars. Next month, on the 21st of April, we will have Dr. Xander Thompson from our anesthesia team discussing equine head shaking. And then in May, on the 19th, Dr. Hannah Sfraga from our emergency and critical care team will speak on advancements in equine critical care. We also have an in-person Cornell Horse Symposium happening at Cornell in June. The date is June 12th, and again, this will be taking place in person. More information on this event, as well as the registration link, will be emailed out next month, so check your inboxes for that. It is now my pleasure to introduce Dr. Shannon Connard speaking on equine tendon injuries, why they happen, how they're diagnosed, and how to optimize recovery. Dr. Connard is a newer faculty member at Cornell. She is a board-certified large animal surgeon who completed her surgical residency at the New Bolton Center, and she's currently an assistant professor of large animal surgery here at Cornell. She specializes in equine orthopedics and sports med and has a PhD from NC State University that focused on advancing the treatment of equine tendon injuries. If you have questions for Dr. Connard throughout the seminar, as usual, please use the Q&A and we'll save a few minutes at the end of her talk to address those questions. And with that, I will turn it over to Dr. Connard.
Thanks so much, Dr. Nickelbein, and I appreciate the invitation to speak. And then thank you all for joining us. I really appreciate your time and hope we can cover some good information and answer any questions you guys have at the end. My email is on the first and the last slide, so feel free to reach out if you guys have any questions or want to chat more about anything we talk about today. So just a brief outline of the presentation today. We're going to go over what tendons are, how injury occurs, the innate healing ability of how they heal on their own, how to diagnose tendon injury, different treatments for tendon injury, and then factors that impact healing overall. So let's get started with just what tendons are. And I know this is a very science-y beginning, but I promise if you can bear with me, we'll get to the cool stuff later on. But this is kind of what I really love. So I want to share that with you guys. So just starting with really basic characterization, I wanted to differentiate tendons from ligaments. So tendons are the tissues in our body that connect muscle to bone. So you can see an example of this here. Versus ligament are tissues that are very similar in nature, but those connect bone to bone and help stabilize. So tendons can have different functional purposes. Some of them are positional, and those help to flex, extend, and move our joints, whereas others are weight-bearing. And so those are included, main functions include load and locomotion. So the big ones that we think about with these in horses are our flexor tendons, which I've outlined here. Again, there are many, many, many tendons in the horse's body. And so I kind of mostly focused on the most common injuries that we see, which are localized to this unit, but that does not exclude others. And if you guys have specific questions about others, I can do my best to help answer them. But just to briefly go over the flexor tendons here, we have the superficial digital flexor tendon, which is the outermost tendon that runs along the back of the leg. Right below that is the deep digital flexor tendon. And then below that is the suspensory ligament. And all of these play a really important role in flexing the leg. And then I highlighted this one structure here called the digital flexor tendon sheath. And I just want to point out that some tendons, especially when they run over larger areas like a joint, are housed within a sheath or bursa. And you can think of this like a joint, but for a tendon. So rather than connecting bone, it encases the tendon, provides lubrication with synovial fluid, and allows those tendons to glide back and forth easily and help with locomotion. So many tendons in the body run through different sheaths or bursa, but I just wanted to bring that up before we get into the nitty gritty. Next, I wanted to talk about how these structures get their nutrients. So, one thing I want to point out is their blood supply. So, everything in our body needs a blood supply to live and function and get nutrients. And so, these first two images on the left show the superficial and the deep digital flexor tendons. And these are angiograms, which is a really cool way of injecting a dye that we can then see show up on imaging like this to outline where all the blood vessels flow within the tendons. And I want to point out that it's very limited and very sparse, especially here in the deep digital flexor tendon. And the other thing I want to point out is that it varies depending on the location. So as you go up higher in the tendon, closer to where the muscle is, we have a little bit more vessels versus as you go down lower, there's a lot fewer vessels here. This I took from a human paper, and I just really love this rendering. And I think it does a great job at depicting the difference in tissues. So again, tendons, we have our muscle unit, and then the junction where it connects to the tendon, where it then inserts on the bone. And you can see within the muscle, there's so many more vessels versus once you get into the tendinous part, there's a lot fewer vessels that can provide the tendon nutrients. The other place that tendons will get their nutrients is if they pass through a tendon sheath or bursa, that synovial fluid can carry nutrients kind of similar to blood supply. So, getting down to the really cellular level, I promise I won't stay here for too long, but think it's important for us to understand what they're made of, and that helps us figure out what treatments are best moving forward. So, cells are one component, and then the biggest component is extracellular matrix. So, this is a magnified view of what tendon looks like. And these small, dark little purple guys are cells that are stained. So we can see the cells that are within the tendon. And then all the pink stuff is extracellular matrix. So that's pretty much what makes up the tendon. And then there are a few cells scattered throughout it. So what is made up of, or what is the extracellular matrix made of? Like most things in this world, it's made of mostly water. So that composes about 65% of it. The next most, or the highest component is collagen. And so collagen actually makes up most of the dry weight. So when we remove all the water, we're left with about 80 to 85% collagen. And even getting into the nitty gritty with the collagen is that there's a lot of different types of collagen. And in terms of tendons specifically, tendons should be composed of about 95% type 1 collagen. So we view this as a good collagen. This is its natural substance, what it should be predominantly made of. 5% of that collagen is type 3. And while 5% is its normal amount to have, what we typically see with healing is an increased amount of type 3 collagen. And this is what we associate with scar tissue formation. So we generally think in terms of tendon, type 1, good, type 3, not so good. Lastly, we have glycoproteins, which, while they make up a smaller unit, they do play a really important role of holding everything together. So when we look at this kind of in a 3D picture, I love these transmission electron micron images, but they just zoom in so closely and you can really appreciate all these hair-like structures that make up the tendon and how they're kind of crimped with this fiber pattern. So really what this is just think of a hair that makes up more hairs, that makes up more hairs, that makes up more hairs. And together these fibers just grow and accumulate until we get the tendon itself. And by being formed in this structure, it makes it very, very strong to withstand these high forces that it must sustain. And then you can see here, this is just a little depiction of the cells within the tendon itself, but again, mostly extracellular matrix. So now that we know what they're made of, let's talk about how injury occurs. And I do want to say a little warning, there are some graphic images ahead. So just want to prepare you for that. But the first and most common type of injury that we see is overstrain. And what we see with this is when there's an amount of stress that's applied to tendons. They undergo stress every single day. That's how we get around. But the stress can increase. And once we take away that stress, you can think of it like a rubber band. The tendons go back and form their normal shape. If that stress is too high, we get to an area where we start to sustain damage and we get tiny breaks in the tendon, which then will not heal and not immediately go back to its normal shape. And then if you take that even a step further, where we add even more pressure, what we'll get is complete transection of the tendon, where all of those fibers will fail. So the stress is really important in understanding how overstrain happens and that we're pushing the tendon beyond its abilities. And so what we see with overstrain is usually we start to get some fibers that tear. And if it's a very large amount of stress all at once, we can even have complete rupture of the tendon. So here are a couple examples of injuries that we see fairly commonly in a lot of the horses that we work with. So this first one here is the superficial digital flexor tendon, and it's a core lesion. So the top image is outlining the tendon, a normal tendon, and this bottom image is outlining a tendon with a lesion. So you can see this big core lesion. The fibers are darker because they've torn and are now missing in that area. And the other thing you can appreciate is it's much larger than the normal one. So we have a big increase in size and a lot of missing fibers in a certain area. Another type of tearing that we can see are linear tears. So instead of occurring in a focal area, these split the tendon in half. So imagine taking a little knife, putting it right in and splitting it down the middle. And so these are a lot harder to find and diagnose, but this is an image of a tenoscopy where we stuck a camera into a tendon sheath and we can appreciate this tear in the deep digital flexor tendon. So those are both examples of overstrain injuries. Next, I want to bring up degenerative injuries. This happens to all of us. We're all feeling it every day, and it only gets worse with time. So one thing that especially comes to mind is degenerative suspensory ligament desmitis. And this, even though it's named for the ligament, can affect the tendons too. We most commonly see this in Peruvian Paso horses, but it affects many horses. And there's a big argument, well, not really argument, but area of investigation where we're trying to understand there's probably some extent of degeneration that then leads to overstrain injury. So a lot of these probably go hand in hand, but this is just kind of a more severe genetic example, but that we're all experiencing some sort of degeneration. Next is trauma or infection, and these typically go hand in hand. We typically will have an open wound somewhere. Horses are very good, I'm sure, as all of you are aware, at getting into trouble. They don't have a lot of muscle on their legs. It's really just skin and tendon and bone. So it's very easily for these structures to be injured. It makes them very fast, but prone to injury. So this is just an example where we can see this horse has sustained an injury. There's clear involvement of the tendon ends, and this is likely in the tendon sheath structure. I want to point out that whenever there's an infection, especially when it's involved in a sheath or bursa, this should be considered a medical emergency and should always be referred because this can be life-threatening. And the reason it can be life-threatening is if the infection is not under control, it can cause permanent damage and long-term lameness to the point where humane euthanasia is warranted. So the sooner we see these, the better that we have the chance of getting them back to a full recovery. But just wanted to really point this out that if there's an infection in an open wound, it's really important to make sure that it does not involve a sheath. And then getting back to the microscopic level, this is just a really great depiction of an injury in the tendon. So you can see the disruption of these fiber patterns where they've been torn, and then they kind of shrink back and fall away from each other as they heal. So these can be really tough to treat. So this brings us into how tendons heal. There's a couple different overlapping phases of tendon healing, and this is a very, very simplified version, but I just kind of wanted to explain them in general because it's important in terms of when we're going to talk about rehabilitation later. So the first phase is inflammation. This typically occurs within the first 1 to 2 weeks, and this is when all the inflammatory cells come in. They say, this tissue's rotten, it's bad, it needs to get out of here. And then it also helps lay the foundation for bringing in healthy cells to start laying down new tissue. So that brings us into the proliferation phase, which kind of overlaps with our inflammation phase. And that's where these cells come in and they start rebuilding the matrix. They start the healing process. They kind of bring in this quote unquote callus that binds the ends and starts to heal. This tissue is quite abnormal, though, and so we then enter the remodeling phase, in which case this abnormal, very disorganized tissue is organized, and this happens over the next 6 to 12 months or even longer. So a very, very long process of this tissue kind of evolving to get back as much as it can to its healthy, normal tissue. But something I really want to point out is that tendon is not very good at healing. So unfortunately, it never really fully regains its original strength. So that's very important in how we treat and move past these injuries. So healing is very poor, as we talked about. It's often prolonged, and tendons takes up to 6 to sometimes 12 or more months for them to heal. And when they are healed, it's typically with scar tissue that's weaker, and the scar tissue itself is actually stronger or more stiff. But what happens is at the scar tissue, normal tissue interface where those two meet, that junction is weaker and more likely to be injured again in the future. It's also less flexible, so it doesn't function as well as the normal healthy tendon would moving forward. And this is due to many things that we talked about. So tendons having a very poor blood supply, they have very few cells, they undergo high stress all the time. The other couple factors that can play a role is age. So the younger we are, the more likely we are to heal better. We have better properties for healing. And the older we are, unfortunately, we run into some of those degenerative changes. And then also metabolic status, which I think we're getting a little bit better at recognizing and diagnosing earlier on. But just like in people, if you have diabetes, it can affect how you heal and respond to different disease processes. So horses that have Cushing's disease or equine metabolic syndrome, those horses are not going to have the same healing quality as others. Now we're going to talk about how we diagnose tendon injuries. So something I really want to stress the importance of is it's really important to localize the source of the pain when you notice that your horse is lame. I've had many horses present that are very lame in one leg. They have a very obvious bump or abnormality somewhere on the leg where it seems like that has to be the explanation for what's going on, but then they block out to a foot and we pair out a foot abscess. So it's really important to not get distracted by some obvious things, but to really make sure that you're targeting the right area. So what helps us localize the lameness is the history, what's been going on, for how long, has it responded to any treatments, things like that. Our physical exam, where we evaluate the horse, making sure they don't have a fever, ruling out infection, things like that. Our orthopedic exam, where we really palpate the legs, the joints, look for any swelling, things like that. And then the lameness evaluation, which plays a big role in a lot of these exams as far as localizing. And so looking at them at the walk, trot, sometimes the canter in some cases, in hand at the lunge or even ridden, trying a different variety of footing, so hard versus soft footing. Especially some soft tissue injuries are more pronounced in in soft footing. So the deeper the footing, usually the more stress that's on the tendon. Flexion tests can help us localize a little bit, but really the gold standard for localizing to a certain area will be nerve blocks. And so working our way up the leg, seeing what area of the leg improves the lameness after we block it, can help us hone in on a very specific area. So once we have the area localized, or if there's a very obvious injury somewhere, we could then go on to some different techniques to further evaluate that injury. And so these are used to identify and then even monitor the progression of the injury throughout treatment. And the first one I want to talk about is ultrasound. This is our bread for diagnosing these lesions and really our first line of defense that we employ. And so this is really helpful here. Just some examples. This is a deep digital flexor tendon that has been completely torn and disrupted. So 100% tear in this tendon. This is what we talked about earlier is a core lesion in the superficial digital flexor tendon, which you can see by this loss of fiber pattern in the center of the tendon. And I just wanted to show you an example of how we can monitor these lesions over time. So this is a lesion from a single horse at week 1 all the way to week 12. And so you can see it's really helpful for us to see the change in the size of the tendon and the size of the lesion over time. And then also you can notice that it starts to fill in with these fiber tendons as the tendon heals. And by the end of this, it's starting to look a lot more like the normal tendon next to it versus the big black hole that it started with. The other thing I want to point out is these lesions, when they happen, typically don't look that bad on ultrasound. But then as you notice here, this is about week 6 to week 8. This is when they get their largest in size. And then they start to heal following that time. So when you see a lesion in the very beginning or an injury, it's usually not, or it's usually worse than it actually appears. The butter, if ultrasound is our bread, MRI is really our butter for diagnosing these lesions. It's especially helpful for tendon lesions that are in the foot because we're not very good at ultrasounding through the hoof. And the deep digital flexor tendon, as you can see in this image, runs all the way down through the foot to then insert on the coffin bone. So there's a long area of tendon that we cannot ultrasound at all that frequently likes to get injured. And so MRI is really great for difficult to diagnose lesions on ultrasound or lesions in areas that we can't easily ultrasound. And so I thought these were really nice images, but you can see MRI is a little bit different from ultrasound, but we can see an increased signal here. So instead of this nice dark tissue, which is the normal tendon, we have this lesion in the tendon, and this is in the deep digital flexor tendon, kind of within the hoof region. So it would be very hard to ultrasound that area. This is a really nice example from a paper that I like comparing different types of MRI. So we have low field MRI and high field MRI. And so low field MRI can be done standing, which is great in that you don't have to anesthetize the horse, but we don't get as nice images, which you can compare to really beautiful images from a high field MRI. And we're really lucky here at Cornell that we have the 3T MRI and are able to get images that are this nice to help us make these diagnoses. These are a couple other imaging modalities that I just want to mention, but not go into too much detail because we don't use them as frequently, but they are helpful, especially in difficult cases. But PET scan or positron emission tomography and nuclear scintigraphy, which is also called bone scan. These systems use tracers that we inject into the horse's blood. And then those tracers bind to tissue that has higher activity. So we typically see tissues that have higher activity in lesions, an area of inflammation. So it can be really helpful for us to hone in on these areas and make our diagnosis. And we can combine these with MRI and overlay them and kind of fit the puzzle pieces together, which makes for some really nice imaging. And then nuclear scintigraphy. So this is PET up top, some examples where we can see some increased uptake in the areas of lesion. So this one is the suspensory branch or proximal suspensory. And then comparing these to nuclear scintigraphy, so you can see increased uptake in this area. These are the horse's hocks. I know it's kind of funny to look at them in this site, but we're looking kind of straight on at the horse's hocks. These are the cannon bones. And then this is a CT image of the same area, just a cut section through here, the same as the PET. And you can see that there's some bony changes. There's a nice little bony point that's pointing in and disrupting the soft tissues. So while bone isn't as important, it still plays a role because the muscle attaches to the bone and the tendon inserts on the bone. So anywhere we have these insertion sites, we can also see abnormalities in the bone. So that's PET scan and bone scan. And then CT scan, you can think of as 3D radiographs, which is really helpful, but again, mostly focusing on bone. So if we think we have bony involvement, that's when we more so jump to CT. Lastly, for identifying is sometimes even though we employ all of our imaging techniques, sometimes we still can't identify really, really subtle lesions, in which case we'll just go to surgery and then be able to look at them and not directly identify them. So this is an example of a navicular bursoscopy. So this is where we put a scope camera into the navicular bursa, and then we can see within the bursa. And this is just a radiograph kind of showing where we're at in the leg, but the foot is here. And so once we're in this bursa, we can see this segment of the deep digital flexor tendon, and you can see this large abnormality on the tendon that needs to be removed and cleaned up to help this horse feel better. Another example is that we can also put the camera into the tendon sheath that we talked about earlier. And within the tendon sheath, we can evaluate the tendons. And this is an example of that longitudinal tear in the deep digital flexor tendon. So we can easily see that, whereas that may have been harder to find on ultrasound or other imaging modalities. So now we know how to diagnose and how to monitor these lesions. And I want to talk about how we treat them. And this is going to be the majority of the lecture. So our overall treatment goals, number one, if involved, if there's infection, it needs to be addressed early on and can be a really important part of how they do. So the biggest impact to start with is if there's infection, getting that under control. Next, if needed, we need to realign and stabilize the tendons. So if it's a complete tear, those tendons we can actually do surgery on or different treatments to try to get them back together and realign them so they can heal better and faster. We also, an important part of treatment is reducing pain and managing inflammation, minimizing scar tissue, restoring strength and elasticity, and preventing re-injury. So starting with medications, again, we talked about if there's infection, we will employ antibiotics to help control the infection. It's really good to have a bacterial culture and sensitivity where we can get a sample of the infection, grow the bacteria, and know exactly what bacteria we're treating and what antibiotics they're susceptible to. And then we can treat with antibiotics systemically with IV in the vein or oral antibiotics, or locally, in which we can do topical antibiotics or regional lymph perfusions, which we can talk about a little bit later on in the talk. For pain medications, this is a combination of pain and anti-inflammatory medications. The first three listed here are non-steroidal anti-inflammatory medications. So essentially are ibuprofen for horses. You all recognize the Banamine and the Bute. Furocoxib is really great, or the Equiox if they're going to be on NSAIDs for a prolonged period. It's a little gentler on the kidneys and just makes us feel a little bit better rather than keeping them on bute or Banamine for a prolonged period of time. Diclofenac is also a nonsteroidal anti-inflammatory, but it's a topical medication, so great for topical application. Other pain medications and muscle relaxants include acetaminophen, gabapentin, pregabalin, and methocarbamol. So sometimes we reach for these, especially if we're not doing an adequate job of keeping them comfortable. I know I was not going to get out of this topic without talking about nutraceuticals or oral supplements. So we're going to chat about them. I really want to caution you that a lot of these can be variable or have unknown ingredient amounts. We also don't completely know the absorption for all of the ingredients and their ability to reach the target site. So just because they're able to eat it, are they actually able to absorb it through their stomach? And then after they absorb it, is it able to get all the way to the tendon injury? So we don't really know that for a lot of these. A lot of companies will have limited regulation and quality control, and more is not always better, especially if you're trying to do multiple supplements together. Some things, especially some mineral micronutrients like selenium, copper, and zinc, if you feed too much in excess, those can actually be harmful. So if you're feeding multiple supplements, it's really good to pay attention to these to make sure you're not giving too much. So knowing all of those, how can I guide you in picking appropriate supplements? What I'm going to say is that they may help support tendon health and healing, but I can't guarantee it. There's limited scientific evidence, and I really want to guide you with true scientific evidence. You can use them as a supportive therapy, absolutely. I do not think they will cause any harm. I just don't know how much they're going to benefit. And they don't replace the primary care that we're providing. So treat them first, and then if you can, add this in as a supplement. Choose reputable companies that can justify what they're putting in, and they can tell you exactly how much of each ingredient is in their supplement and really show the data that they look into those and prove that rather than just saying it's in there when it's really not. And then get proof and talk about all of those things. Do they have any studies where they show that these supplements are absorbed and that they reach the target tissue? Or is there any evidence of studies where they're used in horses with tendon injury and what were the outcomes? So really looking into that from non-biased parties is the best information I can give you. The other thing from a science perspective, so this is from humans and horses, but these supplements are potentially beneficial and or have been shown to actually be absorbed. So if you're looking for a supplement, these would be good things to look for within the supplement. And these are a list of how they might help, and it is backed by the literature. So I hope this provides you a little bit of guidance when picking out supplements, but just always use caution, do your due diligence, and make sure that you're investing your money in something that is actually maybe going to help. Moving on to biologic therapies. So biologic therapies are treatments derived from natural tissues or living organisms. So examples of this would be collecting blood, bone marrow, or fat or adipose tissue from either the patient themselves or a donor animal. And the goal is to kind of manipulate these products to enhance natural healing and improve tissue repair. So, for example, these tissues or blood will be harvested and we process them to concentrate different healing factors. So, platelets, growth factors, cells, anything that contributes to the body's natural ability to heal, we're trying to maximize those and concentrate them into a single treatment. And these are really nice in that they can be administered directly into the lesion. So we can inject them with ultrasound guidance, or do a regional perfusion. So here is when I talk a little bit more about regional perfusions. So this is where a tourniquet is placed on the leg, so a tight band that blocks off the blood supply temporarily, and then we can inject either antibiotics or treatments locally into the area and have them absorbed locally at that site. So we're providing the treatment as close as possible to the injury. So there's a lot of biologic therapies, and unfortunately, we don't have time to talk about all of them in this seminar. But thankfully, Dr. Amy Colbath actually did a talk on these for the Cornell Equine Seminar Series, and this was in December of 2023. The link is at the bottom. So if you want to go back and get a refresher on these, this is a great seminar to do so. The biggest thing I want to point out is that for these therapies, platelet-rich plasma and mesenchymal stromal cells have been the most studied and have actually been shown, and there is some evidence that they decrease the re-injury rate when used for treating these injuries. So I'm not saying the others aren't helpful, but we just have the most information on these two. Talking about surgery, so again, only if indicated, but the goals of surgery are to manage contamination if there's a wound or treat infection if there's an active infection, and then restore alignment or stabilize the tendons, especially if there's a major disruption or tear. So first we're going to clean and flush. The solution to pollution is dilution. So cleaning out as much as possible is always the goal. We can do tenoscopy or bursoscopy, like we talked about earlier, where we stick the camera in these areas, and we can see the lesion and then clean it up with different instruments. So this top picture here is an example of what an infected sheath looks like, where you can see instead of having this normal, nice kind of white tissue background, everything is really red, really inflamed, really angry. So we usually go in and then clean out any abnormal tissue as best we can. For getting in just to clean up lesions. So this is an example of the deep digital flexor tendon with a tear. And this is an instrument we can use to kind of bite away the torn tissue and remove that, because once it's torn away and floating in the wind, it's not going to contribute to healing or anything like that, and probably just cause more problems. So we want to clean that up and kind of set it up for healing. And then lastly, we can do tonorrhaphy, which is a very fun word. But so if you have a complete transection of the tendon where it has completely ruptured, we have a few techniques for suturing these back together, and can try to align and bring back together those ends so there's less distance for that tendon to have to heal. Because remember, these tendons are under a lot of stress. Another very cool treatment is called 10x. So this was brought over to our field from human medicine. And the nice thing is it's minimally invasive, so no open surgery or procedure. It uses high frequency ultrasound to break down and remove injured tendon while preserving healthy tendon. So it's really cool. It's essentially a very large needle that vibrates in the lesion, sucks out the bad liquid, and then you can treat a nice healthy lesion. So this has been adapted to horses. It has showed improved healing on ultrasound after being used, and initially in very small numbers seems to reduce re-injury, but a lot more information needs to be on this. But the nice thing is this can be done standing with the area numbed in most cases. Bandaging and support. So this is very case dependent. So depending on what tendon is involved and what the injury is, it's great for protecting wounds or surgery sites and then providing support and reducing swelling. But it's really important that these be applied properly and properly monitored. So we want them to be adequately padded, tight, but not too tight. We don't want to cut off the circulation, and then making sure they stay clean and dry and in place. Talking about cryotherapy and thermotherapy, so hot and cold. Looking at cryotherapy, it's been shown to reduce pain and inflammation. The cheapest version of this that we all have access to is soaking in ice water. There's also some commercial available units that you can kind of wrap around the leg or certain areas that can cool that area. And then there's also some very fancy hydrotherapy spas, saltwater spas that you could send a horse to, especially if there's like a rehab facility nearby. Alternatively, thermotherapy or heat. You want to avoid this in the early stages of injury, but it has been shown to reduce pain and improve flexibility, especially when there's scar tissue built up later on. And this can be done with heating pads, warm compresses, or therapeutic ultrasound. For both therapies, it's really important to monitor the skin closely. You can cause damage to the skin if these are done inappropriately or too long. Next, I want to talk about high power laser therapy. So I just want to clearly specify that high power laser therapy, these are class 4 lasers, and they function at very high powers, so greater than 550 milliwatts. They work by photostimulation, which is just a fancy way of saying they kind of activate the cells. You want to avoid this anywhere near the eye or tumor or really highly vascular areas with a lot of blood supply, but it's been shown to be clinically safe in horses. It's reduced lameness and inflammation and improved healing on the ultrasound and cellular level. Just to briefly talk about low power laser therapy. So again, this is a lower power one, often called low level or low intensity laser therapy or cold laser therapy. This has a limited ability to reach the depth of the target tissue that you want to hit. So one study showed that in trying to treat superficial digital flexor tendons, so this is the outermost tendon, the closest to the skin surface, that only 1.8 of the waves were absorbed. So very, very low number, not very effective for this area. And that's the most superficial tendon. So I just want to say that we need more information here, but that we're not super convinced that it gets to the area we want it to be getting to. Things that you can do to improve the penetration are clipping and cleaning the area with alcohol, though. Next is extracorporeal shockwave therapy, sometimes referred to as ESWT. This has been shown to reduce pain. It also stimulates the cells to release healing factors, and you can even use this in combination with some biologic therapies. So, for instance, if you inject stem cells, you can use this to kind of stimulate them after you inject them. Same for PRP. This can give variable results, though. From the current literature, it seems to be more effective in ligaments than tendons. And we really need more research to identify the benefits and then develop protocols for different injuries. The hard part about this is you're probably going to treat a superficial versus a deep versus a suspensory ligament different versus injuries other tendons on the body. So it's really probably going to evolve over time, but we'll probably see a very tendon and patient specific regimen come from that. These I just wanted to discuss briefly as therapies that have been shown either effective in human medicine or other areas, but really require further validation in horses. So the one is acupuncture. I'm a big believer in acupuncture. I love it. We don't have any studies, though, in horses really looking at tendon and ligament injuries, though. So it would be good to look at those in the future. There's a therapy called blood flow restriction therapy, which, similar to what we talked about earlier, is we put a tourniquet or a tight band on the horse's leg. And that restricts the blood flow, but they found it kind of almost stresses the area like you would in exercising, but without putting the pressure of exercising on the tendon. They've used this in horses and shown that it doesn't have any negative impacts, but we're not sure how much it helps. But it's an interesting therapy that's shown to help in people, especially with Achilles tendon injuries. And then the last one is transcutaneous electrical nerve stimulation. And these are often called TENS units. So this is just an example of a unit. And I could only find pictures of these on horses' backs or different areas and not their legs, but is a potential therapy and has been shown beneficial in people. So it may carry over. But again, we need more information. Next, I want to talk about therapeutic shoeing. So, like many issues in horses, it's really great to have that collaborative uh, group with your veterinarian and your farrier working together to figure out what best works for your horse. So for shoeing and trimming, the goal is to limit the stress on the tendons. And again, this is lesion dependent. So it's going to depend on what tendon is affected and how bad it's affected. There are some specialized shoes. So this top example here is a horse that had a complete tear in one of its tendons. And they made this special shoe to elevate it and take a lot of pressure off the deep digital flexor tendon to let it heal before dropping that down slowly. I just wanted to point out a few different things between the deep and the superficial digital flexor tendon. So the deep digital flexor tendon heel elevation is helpful. And so this can be done with a graduated shoe or a wedge pad. And then a larger surface area in the heel region. So this is these shoes in the bottom of the screen show that they're really wide, especially in the heel area, which provides more support. And then for the superficial digital flexor tendon, it's kind of the opposite, or just something we want to heed, in that there has been a study that showed that if you increase the heel or elevate the heel, that it may actually increase the tension on the superficial digital flexor tendon. So not all tendon injuries are created equal, and you really want to work together as a group to figure out what the best way to shoe your horse is. Okay, moving on to one of the most important parts. A lot of these were really nicely outlined in this article. I can't recommend it enough. Guidelines for formulating rehabilitation strategies for equine tendon and ligament injuries. These authors did a phenomenal job of writing all of these out, how frequently to do them, how often to do them, describing exactly how to do them with pictures and images. So I can't recommend this enough. I think this is an awesome review. So this is just a list of the physiotherapy and core strength exercises that they have. But just to name a few, wither pulls, tail pulls, standing on a wedge pad, increasing weight resistance, and range of motion exercises are a couple they talk about. So now I'm going to go through a very general rehabilitation program. This is not a hard and fast program. It's just a general one for kind of an average injury. But please know that these will be veterinary guided and very individualized to your horse and their injury, and that progress depends on the injury, their comfort and healing, and how they respond throughout the whole rehabilitation program. So just breaking this down into 6 phases. Again, this article did a really nice job of going through this. But so this is kind of in the early inflammatory and painful phase. We want to provide local and systemic pain and anti-inflammatory medications, cryotherapy for the injury, and then you can start your physiotherapy and core strength exercises, but you want to do so the lighter versions and very gradual. Um, Entering into this phase, probably about halfway through, you can start short, controlled hand walks, probably for about 5 to 10 minutes, 1 to 2 times daily, again, as their comfort allows. The next phase, we're looking at 1 to 3 months. If you can back off the systemic medications, that's great, and only do local pain and anti-inflammatory medications, that's preferred. But if they need more, we can always keep them on it longer. Again, continuing with cryotherapy or cold therapy, especially after exercise, and then those physiotherapy and core strength exercises, and then gradually increasing the hand walks by 5 minutes weekly until they're walking for about 30 minutes twice daily, again, as their comfort allows. Phase 3 will be around 3 to 6 months. And then again, if you can back off the pain medications, always good. At this point, if you want to, especially if there's thickened tissue or scar tissue, you can use some heat therapy, especially before exercising, and then continuing the cold therapy after exercising. Continuing those exercises, and then you can introduce hand walks with gradual weight loading or ground pulls. Phase 4, again, if you can back off all pain and anti-inflammatory medications at this point, that's a great sign. You can continue all of the exercises, but add in gradually increasing hand walks under saddle. And then on the off days where they're not under saddle, continuing just their hand walking, and then eventually add in ground pulls. Phase 5, you can gradually start to increase trotting under saddle. So I would begin with something very low, like 2 minutes, and then gradually increase by 2 to 3 minutes per week until they're trotting for 10 to 15 minutes. And again, if at any point they become more lame or this is not working for them, you need to stop, go back to the lighter version of what you were doing, and then have your veterinary reevaluate them. For phase 6, this is getting into the final end of healing and remodeling. This will be at 8 to 14 months. This is where you can gradually start increasing cantering, just like you did trotting, and then really return them to full exercise if they stay comfortable. So that was just a very general program, but again, you'll tailor that to your horse and their injury. And I want to next talk about what really affects healing. So breaking this down in terms of prognosis or outcome, just some very general guidelines. Again, these aren't hard and fast, but just kind of general. It's better if lesions happen on the front of the leg versus the back of the leg. The tendons on the back of the leg have to do a lot more work than the front, and the front can come back from a lot more. It's also muscle heals better than tendon. So if there's an injury in the muscle area versus the tendinous portion, that tends to heal better. The smaller the lesion, generally, the better the prognosis, with the larger or complete transections being poorer. Um, to have any wound or infection is also complicates matters. And then adhesions formation. So we can talk a little bit more about adhesions, but essentially adhesions are scar tissue, and that can occur around the tendon and prevent it from gliding or moving as easily. So some of our treatments are focused on preventing or reducing adhesion formation. So the key takeaways, I hope you guys can be patient and just understand that tendon injuries can take a really long time to heal. You're doing a really great job working with your horses, and I know it can be really tough to get them through 12 months of healing and then deal with a re-injury. Healing tissue is going to be weaker than normal tendon, so there's always a risk of re-injury that we need to be cautious of. Localizing, early diagnosis, and monitoring are really important to guide treatment and the regimen. There's no single magic treatment. We're working on it. Hopefully, we can get something a little more solid to you. But again, I think this will be very injury dependent. So again, we're doing our best here, and hopefully, in the near future, we'll come out with more and more therapies that can improve the outcome of all of our horses. Rehabilitation is a very important part of recovery, and very time consuming as well. I know it takes a really long time to spend 30 minutes with your horse every day doing the hand walking, doing those physiotherapy exercises, but I'm sure some of you have also gone through PT for different injuries and know how tough that recovery path can be. And then progress must be gradual and guided by your veterinarian. And I should have added farrier in there as well, because they play a really important role in their care. So at this point, happy to field some questions as best I can. But again, if you guys have any things that we don't get to or want to talk about your horses in particular, don't hesitate to reach out. This is my email. And thank you all for your attention and time.
Awesome. Thank you so much, Dr. Connor. That was an excellent and really comprehensive yet straightforward talk. We appreciate it. We have some questions coming in now. First question is, should tendon boots be used for exercise after healing? Do you have any thoughts on that?
Tendon boots. I think they could certainly be added into your exercise program. And then as long as your horse is tolerating it, and doing well with them, then I wouldn't hesitate to add them in. And again, just like all stages of the rehab program, gradually is always better. So start small and then add on. It's also good as you're adding to your rehab program to add one thing at a time. You don't want to introduce three new exercises in a day, but really just focusing on these little areas, and that can help you define, oh, this really helps, and we're responding well to this versus we need to take a step back, or maybe that wasn't so helpful.
Excellent. Another question, is there a specific healing percentage or specific healing goal that should be met before hand walking is started? Or is hand walking something that can be introduced really early in the healing process?
That's a really, really good question. You guys are asking all the good ones. So as far as when they start hand walking, I really base their rehab regimen off of their comfort. So to me, if it looks bad on ultrasound, it would have to look really bad for me to say to not hand walk. But what more helps guide me in that is their comfort level. So if they're comfortable doing that short amount of hand walk, that's the most important thing. And then going up from that very slowly. And again, if they're at any point they become more lame, you have to take a step back and not push them further. So it'd have to be a major abnormality on ultrasound for me to say we should wait longer. And that would probably be more of the tears that are 50% or more to hold back on.
Excellent. Are there specific conformational characteristics and biomechanical characteristics that predispose a horse to tendon injuries? And if so, are these identifiable on a pre-purchase examination?
Great question, you guys. You guys are really knocking it out of the park. So confirmation, yes. Especially with the foot. Again, this will vary for the different tendons, but thinking of where each tendon attaches or comes from is helpful in understanding this a little bit more. So the one I'll talk about is the deep digital flexor tendon and how it inserts on the coffin bone. So it goes all the way down to the foot and inserts there. So that being said, any subtle shoeing changes or abnormalities can put less or more tension on the deep digital flexor tendon. So we don't know all of them, but anything I would say that deters from normal significantly is probably going to be putting some different stress on some area. And just things to watch out for are like major things that really stick out to you. I'm sure over time we'll identify more and different conformations that we notice, oh, horses with straight hocks have more suspensory injuries or things like that as time evolves. But right now, I would just say stay away from major changes that you notice on pre-purchase exams.
Excellent. That makes sense. A question about tendon sheaths versus tendons themselves. Do they heal differently? Does the sheath heal quicker than the tendon or vice versa?
Great question. You would think because the sheath provides extra nutrients that they heal more quickly, and they might heal more quickly, but we've actually seen that tendon lesions in the sheath don't heal as well. And the reason being is the synovial fluid provides lubrication, just like our joints move back and forward, our tendons glide. And so when it gets into the wound, that's in the tendon or the injury in the tendon, it kind of acts as a lubricant and prevents that area from healing. So while it does have the nutrients more so needed for the healing, it actually is kind of a little bit of a barrier. The other really frustrating thing that we see with tendon sheaths is that when we have injury, sometimes they actually heal too well and form scar tissue where they shouldn't. And so those are the adhesions that I briefly mentioned. And so when an adhesion forms, it forms between two structures. So if it forms between the tendon and the tendon sheath, it's going to prevent that tendon from moving and gliding normally, or it can form between the two tendons themselves and prevent them from moving normally. So that is kind of an extra added complication that we see with the sheath. And then the last thing I'll say about the sheath is if it's infected, that's definitely a medical emergency, like we talked about earlier. So infection always complicates things if it's present.
Got it. Thank you for that. One last question to wrap up with. Are there any restrictions on combined treatments, like combining laser therapy following a regenerative treatment with stem cells or PRP?
Really great question, and we need more information on that. I don't think there would be negative effects because all of the therapies we use should be stimulating the cells and encouraging them to help heal the environment. So I would be surprised, but we still need more information. They have combined shockwave with some of the biologic factors, so like stem cells and platelet-rich plasma. And those have been shown to help improve both inside the body and outside of the body. But as far as laser, we need to look into that a little bit more to show the evidence.
Awesome. Thank you very much for that. Alrighty, I think we'll end there right at 7 p.m. Thank you everyone so much for joining us this evening, and thank you, Dr. Connard, for an excellent presentation. This presentation will be posted on our YouTube channel within the next few weeks. You can look out for that. And we hope to see you all next month at the seminar. Thank you.
Thank you.